Thank you for joining the Spina Bifida Association's New Voices for Spina Bifida information session, an interactive session focused on mobility, independence, and quality of life for people living with spina bifida, presented by Chris Toelle and Eric Weber of the Hanger Clinic. This session will cover foundational concepts in spina bifida care and explore how orthotics and advanced devices like Agilik can support movement and participation at every stage of life. Through patient stories, the presenters will share how the right supports can transform daily experiences from walking and playing to preparing for the future. My name is Judy Thibodeau, and I'm a member of SBA staff. Now, I am pleased to introduce tonight's speakers. Chris is a licensed board-certified orthotist, bringing over 28 years of experience to Hanger Clinic. As the National Orthotic Specialist, he provides clinical and educational support in the areas of orthotic design and application, and specializes in lower extremity and cranial solutions. Eric is a licensed certified prosthetist, orthotist, and a fellow with distinction of the American Academy of Orthotists and Prosthetists. He has managed the clinical operations of multiple prosthetic and orthotic clinic locations, overseeing the evaluation, design, and fabrication of prosthetic and orthotic interventions. Welcome, Chris and Eric.
Thank you so much, Judy.
Thank you, Judy.
We're thrilled to be here, and thank you again for all of the support, collaboration that we've had. We're really interested in combining with the SBA and furthering its mission for clinical education, advocacy, research, and we hope that this orthotic management few minutes that we'll spend together on spina bifida care fits somewhere within that paradigm. We're honored to be here. As Judy said, my name is Eric. Judy mentioned myself and my colleague, Chris. I am in Seattle, Washington. Chris is in Sarasota, Florida. And we have a third clinician, Nolan Wilson, out of Tulsa, Oklahoma, who will help take us through a patient story with Trevor Coburn. So we're again honored to be here, and thank you for the time. I will say on the outset that if you have questions or concerns or comments, please put them in the Q&A. Stephanie and Nolan will be monitoring that. Feel free to interrupt. This is an informal discussion, and we hope it sparks thoughts within you and your families' lives. Historically, when we speak to associations like SBA, what we really find is that the families or those affected really have come to us saying that they really didn't know that there was another choice in orthotic management. So there are always better ways to skin a fish, or different ways. So what we'd like to take you through today, as our focus is on orthoses, is how do we arrive at the decision we do when we manage a spina bifida patient orthotically. And it comes from a lot of places. Sure that we can keep our eyes on it as you come into our doors, but it's informed by what the physical therapist has learned about you. It's informed by what your doctor or your surgeon has seen about you. It's informed by your family or health support system around you. All of these things inform our decision-making. So hopefully you'll understand that process a little bit better. And the bulk of our discussion towards the end will focus on the difference between what we traditionally use as orthotic care and contrast that with some new innovations that we hope to preview here. So let's start with Nolan. And if you could please, I will share a different screen and we'll meet Trevor. And then Nolan will talk about Trevor. A word of advice, this is a little bit quiet if you don't turn the speakers up in your computer. So,
hi, my name is Trevor Coburn. I'm a para-athlete with spina bifida, and I've been competing in adaptive sports since I was 8 years old. Growing up, my life looked a lot different. I was in pain a lot, and mobility was a lot more challenging. But when I was 13 years old, I went to my first Hanger Clinic, and I got my first pair of splints. That moment was completely life-changing, to say the least. And Getting my first pair of splints gave me the ability to walk without pain for the first time. It gave me the ability to really push myself and to see what I was capable of doing. Because of that, I was able to try new things, and I was able to find my love for sports. Because of that, I have been able to travel all around the country. I've been able to meet awesome people and have so many amazing opportunities. My life has changed for the better because of it, and it's something I'm incredibly thankful for. Fast forward 10 years, I'm married to the love of my life, Hannah. I have a job that I love, and I'm pushing hard for the goal of making it to the LA 2028 games, competing in archery. And life is amazing. If I can leave you with one thing, it would be that if you are dedicated, never quit. If you are willing to tackle every challenge with a smile on your face and keep pushing, sky's the limit. Life's amazing. Have a great day.
Thanks, Trevor. I hope you understood that, but if not, Nolan, if you could remind us what kind of an amazing patient and person Trevor is.
Yeah, so basically it was hard to hear because he's outside because it's impossible to get him to come inside and sit down for a couple minutes. Luckily we were able to just kind of get him to share some words of wisdom and just some advice to some people that have been through it. His story is a lot like everyone else or a lot of other people living with spina bifida, right? Grew up as a kid, wanted to keep up with his family and just move around. Can you click one more, Eric?
Yep.
So one thing to know about Trevor, obviously he was born with spina bifida. His lesion is lower leveled, so it's a little less involved, right? Don't take, I think you have to take that with a grain of salt because there's spina bifida is a wide range, mobilities everywhere, but he never stopped trying to improve, I think is what's really cool about Trevor. He truly does have a smile on his face, and we've kind of learned through lessons that's something to go. But so starting here, Trevor, he's from Beggs, Oklahoma. He's 21. But so going back to childhood, as he kind of talked about there, never could keep up, falling, breaking bones, just in pain. Not unheard of. Unfortunately, there's more things out there. It's kind of a full circle moment for me. Spina bifida has been in my life 20 years before I was born. My mom was the primary caretaker for her little sister with spina bifida that used full leg braces to transfer only, wheelchair bound. Could transfer and move around with, support. Things are improving to where with that level, you can get out there with the right tools. And I think we're going to kind of shed some light on those here in the future. But yeah, so, and as you grow, when you're 12, you have one goal, some needs. Now as a functioning adult, in society, everything's different. That picture right there is he just sent me that the other day, and it's so cool because we made those braces. He was having some trouble, and the goal was I have to be able to walk down the aisle. Like that was the goal. So we made new splints, as he call them, orthotics braces, with that goal in mind, and it's crazy that a kid 4 years ago had no desire to do that, and then all of a sudden he shows up one day and says, "Hey, I have something new I have to tell you." So it was a really cool experience to be a part of that. He works a full-time job. He works at Shields, which is a Bass Pro Shop, a full-on store. He works in the afternoon, so he's on his feet from 3 to 10. And then he has to go home, be a husband, take care of his house, take care of his yard. just a different needs than a 14-year-old or a 10-year-old. So it's kind of cool that orthotics braces have went such a long way that we can kind of bridge all those gaps. But so speaking to him just a little bit, couple pictures of him. I think something very interesting about my job is that every foot is different, or every patient is different. And so this is one guy with the same deal, and you can just kind of look at his heels and see they're falling in one direction. They're going to the left from behind. I call that windswept. It just is, through the lack of muscle control, his body wants to fall to one side. I think that's his hardest problem. He really struggles to stand still. Eric, I think you're sending me a message, but I got you. So that's kind of that. He uses an SMO AFO combination. SMOs hold his ankles, and then the AFOs kind of speed up his alignment and help him stand taller. One biggest challenge. I think this is probably the biggest challenge for a lot of people. He struggles with it to this day. And the reason we use these pictures with the wounds on, or the bandages on his feet, just to kind of highlight that. He got into a bad habit once he moved to his own and stopped checking his feet. He can't feel them, and developed some sores I didn't know about. He didn't know about it, until it became a big problem. It's a possibility. Just something to think about. And self-care is important, just to really pay attention to what's going on. One more, Eric. So two sets of pictures here. In each set, the picture on the left is no braces. When his pants are pulled down, he has his braces on. I think, to me, on the left, the heel at the first step, that's at the same point in time. He's much more extended. He's taken full stride, equal, more efficient steps, but also with no braces on, his foot just kind of slaps the ground. No shock. It just kind of rocks him. You can see it jar him. Then on that picture on the right, you can see his heel comes down. His whole leg kind of absorbs it and takes that full step. And the same thing on the two pictures on the right, the middle of the stance phase, he's more vertical. His chest is up. His eyes are up. I just think it's so important. You can just tell he's walking confidently. Not always, right, when you get your first pair of AFOs, but for him, he gains 3 inches of height. He was laughing the other day. When he wakes up in the morning, he has to look up at his wife. By the time he puts his braces on, he can see her eye to eye, which is just it's giving him that confidence to, tackle what he needs to tackle and start moving. So it's pretty interesting how much just a little bit of AFO or a little bit of orthotics can just benefit mobility and help to keep people moving.
It's a really good reminder that individuals with spina bifida are also adults with spina bifida, and we're not just treating younger adults or small humans. This is something that interacts and can touch the lives of many stages of life. So just a couple of brief reminders of what we're talking about, and then I'll turn it back to Chris, my colleague, for a bit. As you may or may not know, and sometimes families are still searching for what this is, we're talking about a neural tube that during development turns into the brain and spine, but sometimes can sneak out of in between vertebrae. And the level and amount of that protrusion is dictating a lot of what the limitations are that we might try to manage with orthoses. All the way from an occulta, which might not even be very visible, could see a little, maybe a hair patch or looks like a a beauty mark or a birthmark or something, to a full sac that might contain nothing, just a meningeal seal or something where the membrane itself has protruded, or it could take along with it some nerves and other things and become a full-on myelomeningeal seal. So of those levels and where it happens is really dependent on how we assess treatment options. Nolan mentioned that Trevor had some reduced sensation, and often what comes along with individuals with spina bifida can be a reduced sensation, along with potential proprioception and balance or standing difficulties, positioning support. And this does not always mean that an orthosis is going to correct that completely, but maybe we want to work alongside of that. Often there are some alignment issues in the upper part of our bodies, like a curve in the spine. If the lesion is at a level that could affect organ function or bladder and bowels, that's also taken into consideration. The real crux of what we do orthotically centers around mobility. So we manage to the limitations of either you or your family member, taking into account any contractures where the joint is immobile, or muscle weaknesses that could be either paralyzed or weak themselves. And sometimes with individuals with spina bifida, we get limitations that are not usual. So sometimes a fixed position of the foot might be when the foot is pointing more up than down. So these are all of the things, plus sort of what would we make this out of, and its connection, or how it closes. How complicated is this thing? Because sometimes the gap in the spine helps to produce some hydrocephalus in this individuals with spina bifida, and so there might be some thinking and learning that we need to make sure we encompass in our treatment protocols. So Chris is going to take us down through the role of the care team.
Thank you, Eric. Yeah, it's important to understand that, it's a collaboration with your care team. It's you as the family or the person with spina bifida that, we want to engage with your physician, whether that's a surgeon or an orthopedic surgeon or general primary care. Usually that associates with some direction or level to a physical therapist that can understand what the mobility needs of that person that's affected with spina bifida needs, and helps them obtain the mobility devices or where to go to get those devices. And then with us, Nolan, Eric, myself as orthotists, we interact with this collaborative team to make sure that we're focused on what those mobility goals and needs are of that individual, and or the support of a family with a child, or as an adult that is ready to function, independently. We build and look at those devices based on what those needs are. Eric, next slide. So, there's always the start of what is visible and what is known of that person's presentation, and that's captured by the doctor, understands the severity of the spina bifida and how that person's affected. And they do that through obviously many different exams and tests to understand what all are the effects. Obviously, there's more involved with some cases than mobility. Sometimes it's bladder and bowel function, developmental concerns, multidisciplinary care may need to be directed, and understanding what's internally happening may require imaging or radiology to be affected. Eric? So, what the physical therapist sees is important as it relates to what we obtain in information to understand what, our objectives are to help with those mobility goals and that person's individual needs. So, understanding range of motion, their alignment and posture. You heard Nolan explain in the case where there was deviations in that person's joints, whether it's at their ankles, their knees, or their hips, or in their spine. All of that would dictate, the needs for what those directions and collaborative efforts are around how to treat the lower limbs with bracing, the sensory deficits that Eric mentioned, and also concerns around skin integrity, skin, development of potential wounds. All of that affects our decision and what we're attempting to do. Eric, I think you're getting the next slide. Eric, you're on mute.
So now we finally come to the point where you might walk into an orthotist clinic, and we try to incorporate all of what you have been through, both as a family or as an individual with spina bifida yourself. And now we come to the functional limitations that we need to address. And that involves identifying things that are working and things that are not working. So do we need to assist or resist one of those joints? This helps really move to the most pressing issue functionally. There aren't magic braces that address everything, but we try to hit the largest limitations first and move up from there. So we try to perform an assessment, not only with orthoses, but not even standing, but maybe on a bench or something where we can assess and really pinpoint the specifics, joints and muscles that we want to do. And this helps us to know if you really need a lot of support or very little. Your hips, and make sure that you're capable of putting weight through your hips and knees and ankles in the right way. We don't want to make any assumptions that your knees or hips or ankles are moving in the right direction and in the right full range of motion. So part of that is identifying, it's not a deformity, it's a limitation in joint positioning. And so those limitations help at least point us into the right direction of how we're going to manage that joint and how we're going to manage the full weight of the body when you stand up. There's another part of individuals with spina bifida that we encounter over time, and some of those limitations are not very correctable. So sometimes we have to accept that this is the anatomical position and do the best we can. Other times when we watch you walk and really drill down on the specifics, sometimes individuals with spina bifida can use some of these limitations as a strategy. So is it really wise all the time to try to make somebody very straight or very balanced as one without spina bifida might assume? And sometimes it's not, because we do have a lot of range in the spectrum of treatment options, from things that are very rigid to things that move with the body that are very flexible. We also want to recognize some of those sensory deficits and really pay attention to how we're pushing. And sometimes a lot of pushing on a corrected position of a foot or an ankle is a lot of pushing pressure. And if somebody is not able to feel where that pressure is, we could break down some skin in a way that could lead to a sore or something. So we really want to make sure that nothing's irritating or rubbing the skin too much. Chris?
Yeah, and I think that, as Eric alluded to, and in the story we heard earlier, is that it's important that there's a communication between the person, the family, of the child, or the young adult, or the adult that has spina bifida. It's important that there's a communication between the orthotist, if they're wearing a device, and a regular follow-up schedule is done to ensure that skin integrity is looked at. We always look at devices around functional goals and, maybe a past history of what their use has been and what's worked for them and what may not be working. And then we look at compatibility of the device to ensure that it helps achieve what those functional goals are. And those functional goals could be for a child to be able to go to school during the day. It could be for somebody to walk down the aisle in their wedding. It could be for, going to work and managing work. And sometimes those devices aren't always going to support mobility, but sometimes they support position. And if somebody is not able to walk and they're having to use a mobility device like a wheelchair, then sometimes they need positioning within that wheelchair to prevent pressure from being, on a certain part of their foot all day, or just in general to keep guidance to not further develop any abnormalities of their alignment. Eric? So understanding the orthosis, what they are at the different levels. Again, as Eric alluded to, sometimes people affected by spina bifida may need a device that reaches from the spine all the way to their toes. And that obviously requires different segments of bracing throughout the body that are interconnected. Sometimes it just requires hip control with knee control and ankle control. And then as we see that different levels of spina bifida could be just an effect of control the knees or the ankles. And then sometimes it's just relative to using a foot orthotic to deviate different pressures and support throughout the foot. Custom molded shoes have been options for people that have had different alignment aspects of their feet where we've had to accommodate different shapes and approaches to support them as well. But mainly to take away from that, it has to be a discussion, a collaboration, and understanding of the referral source and understanding of the user being the patient or child or adult with spina bifida, and then what the offerings can be from the orthotist. Eric? So, again, spina bifida, how it affects the mobility. We use the word gait, which is, what we see when somebody is walking, or how they're being supported in a position within a wheelchair for their mobility with their spine or their seating position. All of those are effects that the orthotist might be involved in. But in this depiction, we are looking at the person's gait and how they're able to function through their mobility of walking, or reciprocation, as we call it. And the knee, hip, ankle, foot are all aspects that we look at to ensure that we can either correct their position or accommodate the position to the best optimal outcome that we can, that, as Eric alluded to earlier, creates function. Sometimes correcting somebody what we think is optimally may reduce function, and in some cases it will promote function. Eric?
All right. So we've come to sort of the meat of what we came here to talk about, and the remainder of our time will be focused on the orthosis itself. One of the communication tools you have is vocabulary when you are interacting with your orthotist. Some decades ago, the orthotic world got together and agreed to stop calling a brace a brace, stop calling a short brace, or a long brace, and instead rely on acronyms. And those acronyms have to do with the bits of anatomy that is involved. So, for instance, a foot orthosis is an FO, an ankle foot orthosis is an AFO, and then you cross another joint with the knee and you get a knee ankle foot orthosis. We're adding to, in the last few months, a microprocessor knee ankle foot orthosis that we'll touch on here in a little bit. And then some more traditional H or hip knee ankle orthoses, or HKAFOs, which could have a component that help to allow the legs to move back and forth. And those are reciprocating gait orthoses, or RGOs. So if you really want to impress your clinicians, come in and say, my AFO has not been working. I think I need to move up a joint into a KAFO, or vice versa, move down a joint because my function is improving. The other thing you can really wow somebody with is the level of involvement of any particular lesion is directly dependent on the treatment level involved. So higher levels are more involved, lower levels are less involved, as the cascading effect down the spine. So in a high level, for instance, L1, L2 in the lumbar spine, we do have usually contractures and weak hip muscles. So we need to immediately be thinking of longer things, KAFOs, RGOs. If we move down a lesion, we might have a bit more strong muscles in our upper hips or things, but we do still have weak muscles that help us to rotate our pelvis, or help to move and advance the limbs side to side. So in these cases, we could maybe come off the hip and move into a KAFO. An L4, lumbar 4 lesion level, we're now dealing with below the hips primarily focused on your hamstrings and the front and back part of your ankle. So now we can look at potentially coming down from the thigh even into an AFO situation. Level 5s are most primarily AFOs. We're dealing with weak hamstrings, glutes, and foot and ankle muscles, but they are stronger than at least an L4 level. The sacral level lesions varies, but more often than not, nothing is really orthotically necessary. Sometimes it helps to prevent further anatomical limitations or deformities down the road, or can just generally help provide a more stable stance when you're walking and standing. So to talk about specifics, Chris is going to take us through that.
Yeah. So as Eric alluded to, with the higher level of involvement requires more support. And this has progressed over the years, but some forms of support are what we call standing frames or parapodiums. These have not been as widely used recently as they were in the previous years, but these are either pre-made or custom-made devices that help hold a child or adult upright that's affected by spina bifida. And it's able to provide support from the front of the leg and with the back of the spine area around the buttocks area. And that helps hold them in and gives them an upright posture. We've even seen some of these models progress to having wheelchair wheels on them where you can be upright and wheel yourself around just like you could. Some of them even have, battery driven where they can be electric, where you can, be able to manage and maneuver throughout your home. There's always some fear of how stable they are, but a lot of them have developed into that type of effort. Next slide, Eric. As the level reduces or the functionability increases, then sometimes we have what we call HKFOs, as Eric alluded to, which it's encompassing the hip. Some of these HKFOs or RGOs or reciprocating gait orthosis will also encompass the spine. The level of involvement or the involvement that the person's been affected by spina bifida will dictate how high up the spine we have to come or how low that needs to be. But mainly the reason that spine portion is there is to accommodate and hold a joint system that may be able to allow that person to transfer weight into their limb, which will then push energy through a joint that then allows the opposite limb to move forward or backwards based on their transfer of weight and helps them start to begin reciprocation in an upright form. A lot of these times, this will require use of a walker, maybe training in parallel bars. Some people are able to manage this and develop into use of forearm crutches, where it's a little bit more maneuverable. Eric, next slide.
Chris, I'm going back one slide. There was a question about frequency and why are parapodiums used less frequent now?
Yeah, great question. Parapodiums, I think, unfortunately, my answer is going to be that I think it's almost been a forgotten item. A lot of what's available today has become ready-made in the wheelchair industry or mobility device industry, where you can obtain ready-made standing frames. In some aspect, that's good, but there's a lot of cases where parapodium, like the one you see on the right picture, which is custom made and built for that person, may still be needed just based on the size of the person, the shape of the person, or the area where the support structure needs to be placed in order to hold that person appropriately in the device. So parapodiums are still something that is out there, just not as widely used because of the availability of ready-made items.
And some of the benefits, Chris, about standing?
Yeah, standing is obviously very important for the function of your internal organs, your bladder and bowel. It's, a fact in studies that it empties better if you get somebody upright. Also, it's very important that you reduce pressure on tissue when you're sitting for long periods of time. It's obvious challenge around people that are seated for long periods of time, that they could develop what they call decubitus ulcers around their buttocks and their tailbone area that can lead to challenges with healing. And then just in general for socialization, confidence. Trevor talked about it earlier with our patient story, that being upright and just gaining a couple inches of height adds confidence to somebody. So if your child or adult can be at the same level as everybody else they interact with, sometimes that just really gains a lot of confidence in their willingness to be mobile and be social.
Great, thank you. Now go back to your regular scheduled slide.
Right. So, as we move down levels of care, the lower lumbar level accommodates sometimes crossing the hip, but more simply, maybe crossing the knee with what we call HKFOs, KFOs, all acronyms for hip, knee, ankle, foot orthosis or knee, ankle, foot orthosis. Eric threw in a term that should be relatively new to the majority of you, and that is called a microprocessor KFO, which you're going to hear about tonight with some great innovation that is coming available for those that need this type of mobility. Most of these devices that you see in this picture, they all do one thing. They provide support, they help provide stability, and they help influence alignment of something that of a limb that might be not going in the direction that we want it to, and we want to ensure that it doesn't continue to deviate in those incorrect positions, as well as also maybe support and prevent unwanted pressures to occur that may cause a wound. As much as that we want to attempt to be preventative, sometimes these devices also apply pressure, and that has to be monitored very carefully to ensure that we're not causing a problem that we're trying to help as well. Eric, next slide. So, the high sacral area, 94% of the children that remain in the community ambulators fall into this area. And typically, as Eric alluded to, is they ambulate with AFOs or that ankle foot orthosis. That's the most common orthosis provided with most ailments or people that have affected mobility. And, making that decision of when to go higher is part of that collaborative effort. Next slide, Eric.
Okay, so this was the whetting of the appetite up until now. The new stuff. The new stuff is really been able to, I would say in the last decade, Chris and I have been able to finally address some treatment options in the way that we really wanted to. So for instance, for a long time, if you used any mobility at the ankle, there was a choice of going a little bit or a lot down or a little bit or a lot up. But in between was not really a thing. We have the thing now. There are several manufacturers that have come up with innovative ways of really allowing some powerful, think of them as springs, but things that we can control the entire step as you move from heel to toe in a much more controlled and exact way. So it's no longer kind of an on or off, but a fluid sense of control throughout the whole part of walking. The materials, and if you look at the standing frames and parapodiums, or if you've ever thought of a KAFO that was made of metal and leather, it's just not as inviting as you think it could. But the material advancements, even from thermoplastics over the last 30 years, have advanced to composite materials. Think of fiberglass and Kevlar, polyethylene, carbon composites. These have made the shells of a lot of these orthoses extremely light and extremely durable and could be rigid. So I don't want anyone on this discussion tonight to really feel like just because it's carbon, it's better. Because sometimes hopefully we led up to this with enough of it depends. It depends on everyone's particular circumstances, what's going to be best. So sometimes plastic is still a good thing. Sometimes more rigid is a good thing. Sometimes lighter is a good thing. The point of this is we do have a lot of options now. And lastly, and this is I think the premiere to the SBA of a KAFO that has a knee joint with power. So I'll maybe say that one more time because it's brand new and it's if anybody reads popular mechanics or scientific journals, they might showcase some kind of a suit or something exoskeletal that you would wear and it would walk for you. This is not that. This is augmented function. This is taking somebody who's maybe walking with AFOs and a walker, or crutches and KAFOs, and adding to the ability of the knee to flex and extend with power, as well as utilize an ankle joint where we can dial in the entire step. This is really, for me, a pivotal moment in the history of orthotics generally. Most longer braces in individuals with spina bifida have had to have a straight knee and a straight ankle and a straight hip to be the most effective. Well, now you can be in a bent knee position and a bent ankle position, and when we got you. So this is exciting. It's a powered motor actuator on the side of a custom KAFO. It's called Agilik, and you can certainly Google it or reference it on our Hanger website. We're not really ready to do a universal launch. It's currently in a limited launch site. So maybe if you live close to one of our sites, which are identified on the website, we can start. We hope to broaden that geographic spectrum starting next year. Something to keep in mind.
Eric, if I could just,
yeah, please.
I saw a post come up about the Agilik, and I just want to make sure, clarify. We have a collaborative partnership with Bionic Power, who is the creator of the Agilik. The Agilik right now, Hanger Ventures, who is a part of Hanger, that provides guidance and funding to help move a innovation forward. And right now, that is our collaborative effort between Hanger Ventures and Hanger Clinic and Bionic Powers, that we are working with them hand in hand to continue developing this product. We are providing this product to those that we feel are qualified or present properly for this type of innovation. And that's both children and adults. It's not just treatment for spina bifida. This is for people with cerebral palsy, spina bifida, some types of spinal cord injuries, some types of traumatic brain injuries. It's really not limited to a diagnosis. It's not limited to, it's presentation based. So as long as the person, we feel that they qualify and have a need where we see that the Agilik can benefit them, then there's opportunity. This also can be done as a single limb treatment or as a bilateral limb treatment. It currently does require a small backpack with a battery that helps provide the power to the units. But all in all, it's a very small, lightweight option. And we already know that the next iterations are being moved forward, and that there's opportunity that you'll see a reduction in the amount of device that's needed as we move forward with the continuing involvement of this innovation.
Cool. Thanks, Chris. I see a couple of questions. If you don't mind, I'll wrap this up with a couple of slides, and then we'll focus on those questions that are coming in. So kind of in a summation way, if the good parts about wearing an orthosis for individuals with spina bifida can include better mobility, standing, walking, independence, stability. So if there are trips or falls or anything like that, that is a reduction with the use of orthoses, protecting joints from malalignment or future deformity. We at the end of the day want an outcome that encourages more steps per day. More steps per day means more cardiovascular system work. More steps per day means the health of the whole body. More steps per day also means lower fracture risk, because bones are stronger when they're weighted as they grow. And if we can, in our job, doing our job correctly, the skin won't really have any issues, but we are very mindful of some of the insensate limitations. couple of challenges because orthoses aren't always 100% great all the time. They do break, they wear out. Folks grow, especially if they start early on. They might not fit next year. Walking with an orthosis is not walking with nothing. There's something on your body, so it does take a little extra effort to walk with them. They don't walk for you, so there is a little bit of work understanding how to position your body a little differently. And needs change over time. So regular interactions with the entire healthcare team, from your doctor to your therapist to your orthotist. So in summary, for individuals with spina bifida, orthotic treatment takes a team approach from everyone involved, including your family, from the orthotist who designs to the PT who assesses mobility and limitations to the physician that diagnoses and or potentially performs surgery. The orthotic management that you get will depend on a lot of stuff, but primarily the level of involvement and by lesion level. In general, the higher the lesion, the more involvement we need to be. There are challenges with orthoses as growth and wear and tear happens, but it's a good time. There are a lot of great innovations, and there are more coming. So to use an orthosis really can improve your mobility, independence, bone density, decrease contractures and fracture risk. And standing, as Chris talked about, is just good for your whole body in a number of different ways. So with that, we'll start down the...
Yeah, we have a couple questions that I'll take the first one, and then
Okay.
I'll read the second one to you. So somebody asked about, I think Juanita asked about, about insurance with Agilik, and that's a great question. And, the good news is that when Agilik was brought into the United States, that it was provided a code, which is coded as the L2006, which falls into the class of microprocessor knee ankle foot orthosis that are already covered by most US payers. With that said, Agilik does have a coverage from Medicare and Medicare replacement plans. Several commercial plans like Blue Cross, United, Aetna, Cigna all have different policies that do offer coverage in that space. They also have policies where it is not a covered benefit. When it comes to Medicaid, we have 7 regions that currently do look at case-by-case review around this type of innovation, and will review it and consider a coverage opportunity if they feel that it's right and there's proper documentation around the need for that specific innovation for that person regarding something like Agilik. We are working diligently with clinical research and publications to help support the efficacy, and you will see somewhere early 2026 there will be a publication that will be released showing the efficacy for Agilik. The importance of that in our research and collaboration around that research is that it continues to move the needle for our payers to understand when an innovation like this is appropriate and how to provide it. We saw that with other microprocessors that we work diligently to release publications that help support eventually getting this as a covered benefit. So that's where we're currently at with insurance. The good news is we have coverage. The bad news is there's payers that still may not cover it, and we just have to deal with that case by case. But if you have a child or you as an adult feel that this is something that could benefit you, you should reach out to us, and we can easily find out what needs to be done and work together to fight that fight. So, Eric, I think the next question I saw was, is there anything just at the ankle foot, or does it have to go across the knee to be effective? I'll let you answer that.
I assume you're talking either two things. So one, are there ankle innovations that don't have a computer in it? And then are there those that do have computers in them? And the answer is yes for both of them. There are just ankle control mechanisms that I mentioned just briefly that have enough oomph behind them to really manage your entire weight and body mechanics as you take a step. Several options of those. We do have one potential computerized ankle It's still kind of clearing the road for insurance at this point, as well as at least a dozen different university or research affiliate ankle powered devices that are on the way. So I think that's probably the next horizon that we'll cross as a group, is adding a little bit more augmented function for the ankle. So I would stay tuned, but in the meantime, there are plenty of new things that are available to help really perfect your step just at the ankle. So that's a good question, Brittany. And then I'm going to leave this to Chris. This is Ryder. How do I get an appointment? My name is Kendall, and my son Ryder is 12 and being seen at Campbell Clinic in Memphis. Been trying a hard time this past year and a half trying to find the right brace. Trevor's story has me moved because that's what I want for my son. Ryder is so mobile, but because of his growth spurt over a year ago and the continuing of growing in weight, we're having issues with doctors and orthotics. Love the question, Ryder.
Yeah, and that's a great question. I'm posting both Eric and my email in the chat for either one of you to reach out to either one of us. Eric and I both have oversight to Agilik. If you're speaking about Agilik, the first thing I would say is that first thing to do is schedule an appointment at your closest hanger clinic, or if you're already under a hanger clinic with your orthotist there, or with your current O&P provider, to find out if this is the right option for care for you as an innovation. We have support both internal to hanger and external to hanger around Agilik to help guide with those questions. If you're already part of hanger, Eric or I can help facilitate the closest location. Eric alluded that we've controlled this launch with Agilik to make sure that it's done properly, that it's done right, that the right people are fit with the device, and that it's not just something that's put out there and not done and done incorrectly. So we have 11 hanger locations currently that are really certified to provide this service. We can evaluate at all of our hanger clinics and then kind of push them towards those locations. We do plan to roll this out to all of our locations over time, and as we see appropriate, when we know a location is ready. With that said, if you email one of us, we can help support an evaluation, get you connected to the right location, and consider and start that process of whether this is the right next steps to look at. So please let us know if that is manageable for you. If not, just email us and then we can at least get you information. We do have on the hanger clinic website, there is direction about asking for information about Agilik as well. And you can reach out there as well, but feel free to email either one of us directly. Eric, anything you want to add there? I do see another question that or a statement that somebody said that they have insurance that only covers for orthotic for diabetes. The one thing I would make sure that you clarify for that insurance is that when they say the word orthotic, sometimes it means foot orthotic is covered for diabetes, because that's a common need for people with diabetes, but it is very possible that they only cover orthoses for diabetes. But I would make sure that terminology and how that's being stated, because if an ankle is involved, obviously you don't need diabetes to have ankle issues or knee issues or hip issues, where an orthotic might be, some type of orthoses might be present. But it is, in our terminology, the word orthotic could be termed as a foot orthotic for an arch support. It's also a term that generalizes orthotic supports throughout the body. So just make sure that that's being read properly.
Yeah, great point.
I do want to hit one. I think we missed Taylor. We're always trying to speed up the process. For sure.
Can you repeat the question?
The question was just speeding up from PT referral to doctor referral to orthotics. A bunch of these are custom made. They do take time. I think luckily, just like innovation is pushing technology and new devices, we're also just speeding up process of making them. Hanger has I don't know at this point, maybe 6 or 7 national labs, maybe more than that, making them every single day. I think in the last year, we've probably cut down time of initial evaluation to fitting probably almost in half. I could be making that up, but I think
Nolan,
just
if I
like
could,
anything else, we're moving fast.
yeah, I just want to add, though, I think to the specifics of the question is, when an order is derived from the physician or the therapist request, just be mindful today that payers are very much requiring what they call supporting documentation. And that typically, although we as the orthotist specialist within the bracing world can derive documentation on why we feel a device is needed, we also are required to obtain physical therapy and physician notes that provide the same support. Unfortunately, that is what the payers are asking for in detail. And a lot of times we'll get a order for a brace, or it'll say, hey, fit leg braces, when we really need a detailed documentation, which then requires us to ask that person to go back to see their doctor. And of course, getting a doctor's appointment is not always the fastest process. So a lot of these affect the time delay that's involved in order to make sure the payer will pay for the device to make sure that person's cared for appropriately. So just be mindful of that. And obviously there's many other factors involved in our fabrication time, our speed time. But as Nolan alluded to, is we are working diligently to always improve that process and speed.
All right. Well, I'll take the last question that we have time for. And it centers around 3D printing. It is a tremendous innovation. I hesitated to put that on our new innovation list, as it's not quite a soup to nuts program at this point. You should be aware that most of, say, Western Europe and some other parts of the world are almost primarily using 3D printing. So we go through a bit more of a rigorous vetting process in the United States to make sure that the right types of plastic that are used in the printers, the right structures, the right thickness, the right webbing, the right makeup is exactly what we want. So Hanger has quite a few very large printers that we're printing in all of them every single day, hundreds and hundreds. So we are pretty much there for most of the AFO stuff. We're still working a little bit on some of the softer foot orthoses, the smaller ones, as well as attaching joints to make it a KAFO. But I think if you ask that question next year, it would be a viable program. Okay, I think, Judy, that's all the time we have. Do you want to wrap up?
I'm trying. Hey, thank you all. This has been amazing, and there's great interest, and we really appreciate your partnership with us and look forward to what happens to us next together. Thanks, everybody. Thanks for coming tonight.